Hi everyone, welcome to this session on the risk stratification. I'm Fraser Battye, I'm the head of policy at the Strategy Unit. And for any of you that don't know the Strategy Unit, we're an NHS team and we specialise in applied analytical work. And by that we mean analytical work of many different types, and some of that will be on display today. A standing theme in the Strategy Unit work at the moment is about the shift from hospital to community, and prime within that, of course, about the desire to stimulate neighbourhood-based models of care. And so what we've done is to share the work that we're doing on these topics. We've assembled a programme, a series of what we've called Neighbourhood Insights, where we're running different events on different topics. We're going to take different perspectives on the question of neighbourhood health. Well, we'll be sharing what we have done, and also we'll be convening others and inviting them in to share their insights. And this is the second in the series of Neighbourhood Insights, and we're going to focus today on risk stratification. And I'll say some more about the topic in a moment, but just for a few bits of housekeeping for the session. You may have noticed already, when you join, you'll be automatically muted. That's not because we don't want to hear from you, but given the numbers involved, we thought it would make the session easier to manage. Your camera will also be switched off during the session, so no need to self-censor, at least in visual terms. If you want to ask questions, we're going to have Q&A at the end of the session today. Please use the Q&A function. You can also, if you like other people's questions, you can upvote them, so you can send other people's questions to the top of the pile. So we'll have some time for Q&A at the end of the session. The way we're going to run things then, we've brought together some really excellent speakers to talk on the topic of risk stratification. And we're going to take them in the following order. First of all, Steven Wyatt, who's the head of research and policy at the Strategy Unit, is going to be talking about the theory of risk stratification. In a sense, what would have to be true in order for the promises of risk stratification to hold in practice? And he's going to be presenting a paper that he and colleagues did looking at that. We're then going to hear from Jess Morley, who is a Strategy Unit strategy. And her PhD was on an algorithmically enhanced NHS, so she's very well qualified to talk about this topic. She, for my money, is a consistently sharp commentator on AI, digital data, and the reality of those things. In particular, I think she's excellent on that. And she's going to be talking today about a paper that she and colleagues produced looking at how the promise of some of the algorithms, the risk stratification algorithms, have actually played out in practice. And then after Jess, another Strategy Unit favourite, Thea Stein, who's the chief exec at the Nuffield Trust, is going to be giving us a perspective, both from policy, because she has that standpoint now, but also more particularly from her role as a chief exec of a community services trust as risk stratification was getting going. And I think it's fair to say, or she said that she will do this, she's going to be sort of bearing her soul as someone who really wanted to believe in risk stratification. And then she'll perhaps sort of share some of the journey that she's gone on as risk stratification has played out in practice. The way we'll structure the session then, each speaker is going to have about 15 minutes or so to offer their perspectives, and then at the end we'll come together for Q&A. Thea might need to leave a little bit early, so I'll just apologise preemptively on her behalf for that. The only other thing I wanted to do was just to sort of clear the ground a little bit, to say something about the topic of risk stratification, to try to get as clear as we can be at the outset, just to say something about what we're actually talking about when we're using the term risk stratification, because this term gets used in various different ways. In this session, we're going to be talking about risk strat as a way of using algorithms to spot individual people in the data. And that's typically in primary care data, but it might be in other data. And the purpose for spotting them in the data would be to intervene early and prevent a poor outcome. And typically this poor outcome would be expressed in terms of unplanned use of hospital-based care. So that's the way that we're using the term in this session. The only other things I wanted to just reflect briefly upon is that that's quite unusual in a sense. Most interactions with health and care services are initiated by the person themselves, but risk stratification flips that logic and says that the services will perhaps initiate the contact. Wherever we do that in health and care services, it's quite rare, but you could think about something like vaccines. Wherever we do initiate contact with people, it's typically because we have an intervention that we think they will really benefit from. So vaccines is perhaps a really good example. And where we have an intervention we think they will benefit from, it's because we've studied the intervention usually really quite well. And so we go off hunting for people who may benefit from it. Risk stratification, in a sense, does not follow that logic. It's more about finding people not necessarily having an intervention in mind as to what we might do. So that, again, there's something interesting and distinct there. And then finally, I guess the other thing I might want to say just by introducing the topic is that the use of risk stratification has as an explicit aim the reduced use of subsequent care. So it does have health gain as an interest, but it is primarily geared up towards helping services reduce the use of services. And so that's the sort of primary aim of risk stratification as we would understand it. So that's all I wanted to say, just by way of introducing the session and the topic. I'd like to introduce Steven now, if I may, Steven Wyatt, the head of research and policy here at the unit, to offer his perspectives on risk strat.
Thank you, Fraser. I was going to start by just kind of acknowledging that the problems that these approaches are trying to address are real. Emergency admissions are very costly. They consume one of the most scarce resource that we have in the NHS, which is a hospital bed. And growth in emergency admissions is a key source of the cost pressures that the NHS is facing. And, from a patient perspective, an emergency admission is a pretty miserable experience to have. If we can avoid them, we certainly should try to do that. And when we do audits of patients who are in hospital beds, we typically find that perhaps a third of those patients, in theory, we could have intervened earlier to avoid that admission or to manage their care in a way that didn't require hospitalisation. So, it's a proposition that we really want to believe. And the health policy world has been very enthusiastic about the idea. The recommendations to adopt risk stratification appear in most of the big health policy documents over the last 10 or 20 years. Now, Jess is going to talk in a bit about what the real world evidence that's emerged over the last few years says about the effectiveness and impact of adopting these approaches. But I wanted to talk a bit before then about what our disposition should be towards these approaches before we see the evidence. Should we be optimistic that these approaches will deliver benefits, sizable benefits, or should we perhaps be a little bit sceptical? And I'm going to try and address that issue by asking two questions, purely hypothetically. The first is whether we should expect risk stratification models in and of themselves to improve allocations of primary care. Expect knowledge of a patient's risk of emergency admission in the next 12 months to improve the decisions that primary care makes to decide which patients it's going to see next week and how much effort and energy to put into those patients and which patients not to see. So that's the first question I'm going to try and... The second is whether or not we expect adopting these risk stratification approaches with aligned interventions, upstream interventions, whether we should expect them to reduce healthcare costs in the round. So I'm going to take that first question about resource allocation. So when these risk stratification approaches land within primary care, they tend to manifest as lists of high-risk patients. And we typically get some information about their risk of admission relative to an average patient, the diseases they might be suffering from, but also their historical health utilisation. And the expectation is that a GP or somebody else within the practice will do something with those patients to reduce their risk of admission. And often an incentive is associated with that effort, financial incentive. I'm going to say something completely obvious now, which is the GP practices are pretty busy places. They don't start the week with gaps in wondering what to do with their time. They are chock full of work. So if they're going to take on board information about the risks of emergency admission, that means deciding to see somebody that they wouldn't otherwise have seen or to give them more energy than they would have given them and as a consequence, not see other patients that they would otherwise have seen in that week. So these are critical decisions they're making. And existing methods that GP practices use to prioritise which patients they see in a given week are incredibly complex and nuanced. They take feeds from all the contacts that received in a given week from patients and their carers. They'll take account of the GP's knowledge of those patients and what they might be needing. They'll take account of discussions that clinicians within primary care might have had with the clinicians in other settings. They'll take account of the clinician's intuition, their experience, the guidance they work to. And these processes that GP practices use to work out which patients to see in any given week, they're constantly being tested in real-world settings and refined as such. And so they have to be safe, they have to be practical, they have to be responsive. They might be from the outside emergent, but in fact they're highly sophisticated, socio-technical, multi-layered processes. The question we ask ourselves is whether it's plausible that knowledge of a patient's risk of emergency admission in the next 12 months might improve those resource allocations. Or is it possible that the incentive that's associated with stratification tools might distort or degrade those resource allocation decisions? Patient's risk of emergency admission in the next 12 months gets less benefit than the patient who otherwise would have been treated without that knowledge. So that's a question I'm posing to you. Should we believe that knowledge of patient's risk score improve those resource allocation decisions? That's the proposition that's inherent in these approaches. Now, to me, that seems like quite a high bar to pass. I'd be very surprised personally if this information radically improved resource allocation decisions within primary care. And I wouldn't be at all surprised if inadvertently it made those decisions worse. So that's the first sort of question I wanted to answer. The second one I wanted to talk about was about whether or not we might expect risk stratification approaches in the round, both the knowledge of the risk score and the intervention that would follow from that to try and reduce the risk of an admission, whether those things might reduce healthcare costs. So I'm going to share my screen now because I need to take you through some maths. Bear with me. Can I just check that you can see that now? Yep. So I wanted to imagine that we are working in a practice with 5,000 patients, so a sort of typical size practice. And we've received some information via a risk tool that identifies 100 individuals that have the highest risk, according to a certain algorithm, the highest risk of an emergency admission in the next 12 months. That's the top 2% of patients. And the idea is that we're going to offer some sort of intervention to those patients to reduce their risk of being admitted. And the question I'm posing is whether or not that is going to be value for money. Are we going to save more money by offering those interventions to those patients relative to the costs we'll save by reducing the number of emergency admissions? So there's a few bits of information we need to know in order to be able to make an assessment there. The first is about the positive predictive value of the model that we're using. So when these models get published, we receive various bits of information about the model accuracy, calibration, discrimination, and a value that's typically given or commonly given on those papers that describe these models is the positive predictive value. And it's quite a simple metric. It's just saying, of the people we identify as being high risk, what proportion of those people will be admitted in the next 12 months? The values, these PPV values tend to depend on the strata of patients we're looking at. If you're looking at a very high risk strata, PPV values tend to be quite high. If you're looking at a more general cohort, maybe the top 10% of patients, then the PPV values will tend to be lower. They also vary between the risk tools that are available for us to use. But the variation between the risk tools on any given strata is usually quite small. So they do vary, but they don't vary hugely. The PPV value for the combined predictive model, which is one of the most widely used models in this space, for the top 2% of patients is 0.36. So that says that of the 100 patients with the top 2% of risk that we've identified, 36 will experience an emergency admission in the next 12 months. So note that 64 of our 100 patients wouldn't have been admitted in an emergency in the next 12 months. So there's nothing we can do to reduce their risk in that sense, at least, in the risk of emergency admission. So any money we spend on trying to reduce their risk is wasted. We can't reduce their risk at all because they wouldn't have otherwise been admitted. We can make this worse, but we can't make it better. The next thing we need to know about in order to work out whether this is going to be cost effective is the effectiveness of the intervention itself that we offer. And again, interventions effectiveness is stated in many different ways, but a common way in which the effectiveness of interventions is expressed is as a number needed to treat. So that says how many people do we need to receive the intervention in order to avoid one adverse event in this context being emergency admission. And as Fraser said, that one of the difficulties with the risk stratification approaches is that we're rarely that clear about what the intervention is that we're going to offer to patients, having identified them at high risk. But for the purpose of this thought experiment, I'm going to assume that we have an intervention that has an NNT value of 18. That is to say that for every 18 patients that we treat, one emergency admission is avoided. I've given some information at the bottom of the slide here about other NNT values for other interventions, so you can get a sense of the scale. A low NNT value means a highly effective intervention. A large NNT value suggests it's a less effective intervention. So this is kind of at the edge of plausibility. An NNT of 18 for this sort of intervention would be very good. But let's assume that's the case. That would mean that 2 of our 36 patients that would have had an emergency admission will actually get admitted. Sorry, that we will manage to avoid their admission in the next 12 months. So we started by treating 100 patients. We've managed to avoid 2 emergency admissions if you take these values that I've given. Now let's assume that those 2 emergency admissions would have cost about £2,500 each. That means that we've made a saving on the commissioner spend of about £5,000. But remember, we've started by treating 100 patients. So that means for this arrangement to be cost effective, the intervention that we offer to those patients, the upstream intervention, must cost less than £50 per patient. And just to give you a sense of scale, £50 would buy you a 10-minute consultation with a GP, something like that, maybe a slightly longer consultation with a practice nurse. So the question is whether it's plausible that an intervention of that intensity would have this level of effect. Now, I've obviously made up some figures to make these calculations work. You will need to decide what plausible levels of these values are. But there's something kind of inescapable about the formula. The cost of the intervention, the upstream intervention, has got to be less than the cost of the emergency admission multiplied by the positive predictive value of the model and divided by the NNT value for the intervention. There's kind of no escaping that truth. You can make better or worse assumptions about the values that might go into that equation, but if it's going to reduce costs, then this equation has to stack up somehow. And you can do that by making the cost of the upstream intervention cheaper, or by making your model more predictive, or by making your intervention more effective. But you've got to figure out a way of making this equation stack up somehow. And whenever I look at this equation, I'm left thinking, well, maybe we can make this work, but it's not altogether obvious that it will. And I think there's a fair chance that we might end up spending more money on the upstream interventions than we save in reduced or avoided emergency admissions. So those are the 2 sort of thought experiments I wanted to take us through today. Is it likely that knowledge of a patient's risk score might improve resource allocations in primary care? And is it possible that adopting risk stratification approaches with upstream interventions might reduce healthcare spend in the round? Before I see the evidence that Jess is going to present, my perspective will be that we should be slightly sceptical. We shouldn't rule it out altogether, but we probably shouldn't be replicating national rollouts of initiatives unless we get a bit more information to suggest these things are really going to work in practice. I'll stop sharing my screen and hand back to you, Fraser. No, that's fine.
That's excellent. Thank you, Steven. And I can see questions starting to come in already. People drawing comparisons with things like, vaccine programs or screening programs, and whether we should subject risk stratification to similar evidential tests as we would to those types of interventions. And also questions coming through about, in a sense, addressing your point that it might make resource allocation even worse. And then people are going at the intuition, well, what if we got, in a sense, what if we got better data? What if we made these things more refined? So we'll perhaps come back to those in questioning. I want to invite Jess now. So Steven set out, in a sense, what would have to be true, sort of almost in principle, in order for risk stratification to work in practice. Now we're going to hear how it actually has worked in practice. So can I hand over to you, Jess, to take us through that?
Yeah. Okay, does this show up? We're good? Okay,
yep,
great.
I can see that. Yep.
Awesome. So thanks, everyone. I'm just going to present a couple of things. I'm going to give you an overview of a paper that was led by Chris Oddy, and then with myself, Jo Zhang, and Hutana Shrarathan, where we basically did a systematic review of exactly what happens when these risk stratification tools are deployed in the real world. And then I'm going to give you a little bit of essentially explaining why the things that you've just heard needed to be true are not true when these things are deployed in the real world. So first of all, this is just an overview of the database that we searched. So essentially, we looked for articles that actually evaluate risk stratification models once they have been deployed. So essentially trying to answer the question, what happens once they're live? Because as will become clear, but it's also very common in the world of data science in general in healthcare, things are often evaluated up front, but not after deployment, which means that they're validated, not evaluated. And it will become clear that this is a bit of a problem. But essentially, we did a systematic review. There were 3,897 articles, which highlights quite how frequently or how heavily densely populated this sort of area of research and work is. And then we looked at 51 studies that were evaluating 28 of the most commonly deployed risk stratification tools. And as you've heard, this all focuses on the theme of risk stratifying for hospital admissions and healthcare costs. And this just goes to show you, this is a little figure that we have in the paper, and it's an idealized view of what the life cycle of a risk stratification tool should look like. So essentially, you should have the data. This is good because I've seen that some of the questions focusing on that. You train the model, you do an internal validation, you do an external validation, and then you deploy it only at that point as a population health management strategy. And then there should be, after that, a sort of impact assessment that's feeding around. Now, what I'm about to show you is that things typically stop here. They stop on that third slide and then, or third pillar, and they then jump straight to here, to the population health management strategy. And then very rarely does this life cycle that continues, the sort of monitoring and auditing happening afterwards, actually continue. An internal validation is essentially mark your own homework. It's a case of, does my model work when I run it on similar data, on similar population to the people that I have trained it on? An external validation would be like giving your model to an examiner, ideally in a different setting, and ideally in the location that you want to deploy it in. And so what we found was that, by and large, as you've just heard as well, when these models are built, their accuracy level, or sort of their predictive performance, is quite high. They do quite well, but there is variability. So they are not consistent in terms of their ability to perform. But in general, when you do a validation study, does this work? It does seem to generally perform quite well. Of the types of risk stratification tools that are available, because not all of them are AI based, some of them are far simpler. They're just based on sort of more traditional medical statistics. Machine learning models do predict better. So when you use a machine learning model that is trying to look at a wider variety of factors that might be associated with risk of admission or hospital costs, that performance is better. They predict more accurately in terms of who might likely to be admitted. And then what we look at, though, however, is that 14 out of those 28 models were validated externally. So they were validated outside of the setting in which they were originally developed and trained. But there were only 2 in the entire set, only 28, which is the Charlson Comorbidity Index and the Johns Hopkins system, were actually validated internationally. So there were only 2 of 28 that were validated outside of the country and therefore outside of the population on which they were originally trained. And yet, as you will see, these things are all deployed internationally. So what this was looking at was a lot of studies that are validated in, for example, Europe, or a lot of them in the United States, and then they are deployed and used elsewhere, including within the UK. And then what we found, unfortunately, this is where I now depress everyone, was that in a lot of things they really don't work. Once they actually are deployed live, the outcomes are often worse than they would have been had those models not been deployed. So we looked at the PRISM trial. This indicated a significant increase in hospital admissions once the model had been rolled out. We looked at a couple of different ones. This elder risk assessment showed that there was again an increased mortality risk once the model was rolled out. And Q admission results, similarly, there was a notable increase in hospital admissions. The Johns Hopkins one, which was the one that is one of the ones that is externally validated, so it was validated internationally, does show some benefits, but what it shows is the problem of bias. I'm sure everybody has heard of the issue of bias, and I know there's been some questions already in the chat with regards to data quality, is that where there were prioritized groups, so the groups that basically the algorithm was very, very, very familiar with, their outcomes did get better. They were successfully able to avoid admissions. But for groups that the algorithm was less familiar with and were not prioritized, their outcomes got worse. And there's a very, very famous study of this, for example. There's a study by Obermeyer, which essentially shows this happening in real time with risk stratification of hospital admissions in the United States. And what it found was that for members of the Black community, they were being consistently under-risked. They were essentially being said, these people do not need to be admitted into hospital, and therefore their quality of care was dropping off a cliff. And then what that was shown to be because they're proxying. So the way in which these models choose risk factors, that what they were looking at was historical hospital admission costs. And as we all know, the history of medicine is biased. And so people who are like me, have high hospital costs because I get access to care. But people who have traditionally not had access to care have low hospital admission costs. And then when the model was predicting off that basis, they were basically saying the people who have historically had low hospital costs are likely to not need the intervention. And so they were being de-risked, which was actually the reverse of what you would want to happen. So that's where you get these sort of patterns of bias not working. And then very similarly, we also had a few that just showed no measurable impact. So they weren't necessarily making things worse, but they were also not making anything better. And therefore, in terms of time efficiency and the amount of time that might be being spent on them, they're sort of a waste of money because they're not really doing anything. They're just adding additional burden to an already overburdened system. And so why is this not happening? You've already sort of heard the theory of what this is. So my sort of framing of this is that it's because it's predicated on false hope. In sort of algorithm literature or AI literature, there is this concept called target misspecification, which is essentially when there is a mismatch between the objective function of the algorithm and the outcome that you're trying to achieve. So this is essentially when there is a mismatch between the prediction and the outcome, which is reduced admissions or reduced hospital costs. Now, part of that is because of the issues that I've just described in terms of that Obermeyer study, where there is the wrong proxy, so there's the wrong data is involved and the objective function is therefore wrong. You're trying to optimize for the wrong thing. But there are other different reasons as to why it causes these problems arise. And so the first one is that it's treating prediction as causal inference. I'm sure everybody knows here that there is a difference between correlation and causation. And basically, this is the problem. We're confusing the two. So the fact that we can predict who is most likely to be at risk of a hospital admission or high increased costs does not necessarily mean that we know why they are at risk, and therefore we do not necessarily know what to do in order to intervene. And there's an enormous amount of sort of maths that shows why that's the case. But essentially, there are some really simple confusions. One of the ones is related to smoking, that they show mathematically is how this works. There are multiple different risk indicators that this person is a smoker. One of them is yellowing fingers. If you take yellowing fingers as the predictive factor, then the intervention could easily be, because you don't know why that person necessarily has yellowing fingers, the intervention could easily be go tell that person to wash their hands. That's not doing anything in order to change their risk. It also targets individuals rather than structures. So you've also heard a little bit about this. Most of the time, risk, although it does come necessarily sometimes from people's actual bodily functions, an enormous amount of the reasons why one population is at risk versus another population at risk is structural. It's to do with the environment in which they live. This might be what you heard from like Michael Marmot with regards to the social determinants of health, but there are also many other different reasons. It might be because they cannot get to the hospital when they need to, or they keep missing GP appointments. Those are things to do with, say, transport structure or how that person is working. So again, this causes some problems. The other aspect of that is that these things are changing the care pathway, but very often the entire care pathway is not remodeled around the fact that this risk strat tool is now in use, which means as soon as you hit the real world, performance drops off a cliff, because maybe you have this person who is flagged as high risk, but nobody knows actually what that means and how you're supposed to organize the care, and those types of things. Then often they mistake information for intervention. This is more a problem when you risk stratify that's deployed at the patient level, which is not really what we're talking about here. But it does also occur in scenarios where we're risk stratifying in primary care. And essentially, it is linked to that first point about the difference between causation and correlation, because just telling you that this person is at risk does not necessarily mean that something can be done about it, especially if we don't know why that risk is happening, and especially if the risk is related to there being structural problems. And those structural problems might be also to do with things like the quality of the data, the quality of the systems in which they are running, or the fact that there is this mismatch between the validation population and the real world deployment population, with this idea of data set drift or population set drift. And then these other two are slightly less important in this particular conversation, but I'll flag them just in case. And so it's optimizing towards a biostatistical ideal. Most of the time, the ways in which people experience health and therefore might turn up to hospital because they are feeling unwell is not necessarily just to do with whether or not there is the presence or the absence of disease. It can also be to do with a wide variety of factors that are sort of biopsychosocial. They're more to do with the person's wider life and their experience of care. Loneliness is a massive one, for example. These models are not really necessarily going to predict on loneliness because we do not have loneliness recorded in a quantifiable way in the models in which they are built. And then the other thing is the reason is again why we were getting that sort of mismatch in the performance between targeted populations and non-targeted populations is that these things assume that what we need is equality rather than equity. And again, this is linked back to this point around the difference between correlation and causation. They assume that what we need to do is predict equally for everyone. That's not necessarily true. What we actually need to be able to do is predict what specific types of people need. And that's very different than saying, does this model work equally well for everyone? And that starts to cause an enormous amount of problems when we're talking about whether or not we have an equal system. So ways in which we can sort of deal with this, these are higher level ones, and then I give you some more practical ones, and then I stop talking. So there are a few. We need to shift in terms of moving away from prediction to talking more about causal inference and trying to actually understand what's driving the risk so that we can therefore understand where we in fact need to intervene. We need to stop looking so much at the causes of individual cases and instead look for more the causes of incidence. So why is town A getting more hospital admissions versus town B, as opposed to why is Jess being admitted to hospital instead of Polly? And then we have things to do with informational interventions to structural interventions. So instead of just telling you this person is at risk, we should do something. What is the actual structure that we should be changing in order to reduce the risk? And we need to look more at the different types of factors and include a wider range of factors that are not so narrow. More specifically, in terms of how do we make sure that these things are safe when they are used in the NHS, because they clearly are not right now, we need to have more risk prediction controls. We need to have a better way of actually sort of standardizing the fact that they are subject to rigorous evaluation. I know we had some people asking the questions with regards to should things be subject more to the sort of rigorous standards of things like screening. My answer to that question is yes, but we should have them be not fall foul of what we would call sort of algorithm exceptionalism, and not just treat them differently because it's information and not something that's intervening in a person's body. This means we need better regulatory oversight. These things should really be classified as a software as a medical device, and therefore subject to higher evidentiary standards and not subject to post-surveillance, post-market surveillance. So once they've gone live, make sure they're actually being monitored and importantly turned off if they're making things worse. We need to do more cost-effective review, and we need to look more at population-level interventions, which is the thing that I was just talking about. These are the 4 conclusions that are in our paper. These are from my wider body of theory. And now I will stop sharing and stop talking.
Jess, I detect from the reactions of people as you were talking that there's no appetite at all for you to stop talking. So we'll invite you back with the Q&A. It's interesting you began at the start of your presentation saying you were about to depress people, and then I detected a flurry of questions about, in effect, how do we salvage this stuff? What could we do to make this stuff better? And then you've pointed to a few at the end, a few sort of correctives that you think you should be in play, and we'll perhaps return to that in the Q&A. I want to hand over now though to Thea. So Thea, if you could offer your reflections on what you've heard, but then also in the way that you've encountered risk stratification and the way that you have seen it play out. And I've got you on mute, I'm afraid.
I think I had myself on mute, but you had taken me off mute, so that was me. But I've been reading all the questions, so many questions coming in, and I feel this is it looks like a very knowledgeable audience who have clearly made a choice to come to this event. And to tell you a bit about why I got here, really, I got here because I read Steve's paper and I read Jess's paper, and it made me realise how completely and utterly I had failed when I was a chief exec in the health service to scrutinise these tools. And that made me very curious. You don't end up being lucky enough to do the role I do now, which is chief exec of a think tank, without being somebody who's very interested in research, interested in evaluation, and generally somebody who sought that out, sometimes to the detriment of, therefore, one's leadership, where you're challenging people and saying, but there is no evidence around that. And yet for these tools, I had done nothing except accept them. And there is something called the illusory truth effect, which is where you accept things because it feels familiar and it feels like the truth. And I have no doubt that that is what I did. There is also something about trust in authority, and something which I would generally say I have made a career of challenging, which I didn't do at all. And so I was really curious when I read both of the papers as to why I didn't do that, because it completely shook and changed the way in which I thought about these tools. And if I was still in an operational role as a chief exec, I would be bringing these papers to the table, which is what I can see many people are talking about in the questions, and wanting to think differently. And I think the reason fundamentally why I didn't question it at all, and why I wanted to roll it out at speed, and I imagine in many of you are in places where that is the case, is because it feels like a tool that gives you control in an experience which in most days in the health service can feel out of control. I also think it's because we do know that we act in the health service often in a very reactive way, and as though things are unpredictable. The classic one would of course be A&E, where for many years we acted as though A&E was unpredictable, but actually we know there's huge amounts we can predict about what sorts of people will present at what time, you know, when you're going to get your children in, when people are going to fall off ladders, when people are going to come in because they're drunk. I mean, it's actually pretty predictable. So I think there is a history in the NHS as well of us saying, if we use data, we get better. And that's true. And therefore, I think there's a seduction about these tools, which feeds into actually some of our learning in the NHS and in other healthcare systems, which is if you use data, you'll be better. And so I instinctively felt, if I use this data, if I can see that 100 people that Steve talked about who are at risk of A&E, I wasn't that bothered about saving A&E money. I was bothered, though, about doing better for them, providing better care. So I think these tools are very seductive in a place now we are in the NHS and in most healthcare systems in the world, where things can feel uncontrollable, where things can feel unpredictable, and it gives you a sense of control and predictability. And the idea that if you could wrap yourself and your staff and your teams around a cohort and think in a different way, you could create the changes that we all want to create. So I try and be gentle with myself and say, it is understandable why you fell hook, line and sinker for all of this. It's understandable why that illusory truth effect was so profound for you. But I think it's essential to listen to the type of research that's coming out from Steve and from Jess, and to then understand where that takes us. I can see somebody, Chloe Stewart, has posted about the NHS England's high frequency user framework, which I think is a useful comment, where she's talking about the fact that you can think about the limits of predictive identification, but you don't have to throw the whole thing out. You're using that embedded in a more, what she's calling their trauma-informed model, also models that take in other aspects of what we understand by the whole of some person's life, which Jess talked about as well. I think it's a salutary tale of what Jess called false hope. But I don't think, therefore, we should be throwing it all away. We should be understanding what we can do with it, what we can do with a really good tool. And I think it's just a fascinating experience of how we still have to bring evidence to bear on these policy decisions, particularly the ones where they feel like they're going to be where the magic happens, because they're the ones that can feel very dangerous. I have learned so much from Steve and Jess's paper, and most importantly, it took me right back to remembering how you have to challenge those things even more closely, where, as I said, where it feels like it's where the magic happens. That's all I'm going to say at this point, Fraser.
Thank you very much. I know you might have to go a bit early, don't you, to attempt to find the train, which which may
I
or may
may
not
find
exist.
a change, may or not exist. I'm uncertain at this point, yes.
Okay. So in order to make sure that we get a chance to give you a question and that you then have a chance to go off and hunt the magical train, I just wanted to give you the question that Kate Warren has asked in the chat, which in a sense it seems to me like you're almost being a little bit hard on yourself as the chief exec when you were getting risk stratification coming into your world, in that you seem to be giving yourself the burden of working out whether this stuff was likely to be any good or not. And I think Kate Warren's question is, well, shouldn't we just have better standards of evidence applied to these tools, such that when they do enter your world, you could legitimately trust?
Of course, absolutely. There shouldn't be something that comes out. But, you know, as somebody who'd been a chief exec in the NHS for many, many years, I did know that I probably had to bring my own eyes to bear on policy, because many, many policy initiatives come out where you go, I don't think there's much evidence that suggests that would be a very good idea. So it would be lovely to be sure that you are always going to have evidence-based policy, but and this is a remarkable example of something that's got so much steam and so much energy, but actually is not being thought through in the nuanced way that both Steve and Jess have put forward. But yeah, of course it would be great if you just go, I can trust this product. I absolutely 100% trust this product. But I think it, you know, it just demonstrates where all of us are, because it feels so, you want control, you want a bit more control. And I still think there's things in these tools that can give you some control, but you've got to understand where it's not going. At the moment, I think we're in an incredibly dangerous policy situation, actually, in the English NHS, where we are developing too much faith and hope in these products. And that's going to be extremely difficult for people, many of whom are on this call, who are going to be trying to deliver at a local level, who will be seen as failing because their tools don't deliver what they were never going to be able to deliver. I think it's very dangerous at the moment.
Thank you. Mahmuda, can we bring Steven and Jess back into the screen so I can see you all? And then Thea, when you need to go, just say that you need to.
Thank you.
I wanted to ask you all a fairly sharp question, which is sort of boiling down some of what is in the Q&A, and it perhaps builds on a comment. Jess, when you were presenting, you said something, I'll just paraphrase and get it wrong. You said something like, these are clearly not safe for use right now. So one of my boiling of many of the questions in the Q&A is, in a sense, well, what should people do? In response to the evidence that's coming through, in response to the studies that you guys have presented, what would you say to people who are currently using these tools in day-to-day practice as things stand? Would you tell them to stop? So Jess, can I direct that first to you and then perhaps come to Steven?
Sure. So my sort of short answer to this, and as already Thea has kind of encapsulated it, I have this phrase where I say, be skeptically optimistic. There's no need to become like a complete naysayer and think none of these things are ever going to make any difference, because it is possible that some of them will. Just don't believe everything at face value. And the way in which you can get around that, ideally before we have all of the things that I would like there to be in terms of regulation and safety, as Thea has just said, is ask really awkward questions. So when somebody comes to you and says, well, we would like to deploy this, just ask all of the super awkward questions. Where was it trained? How was it validated? Have you got any long-term evidence of it actually working? Do you know what the outcomes are? And then the other thing is, if you want to test it, that's okay. But there are two things there that you should do as a consequence of deciding to do that deployment. One is monitor it over time. So a lot of the big problem that we were pointing out in that paper is that these things go live and then nobody ever checks to see what difference it's actually making. So you should just be looking to see what difference it's making, which means do more auditing. And ideally, you should have some sort of things built in to say, at this point in time, we're going to stop and we're going to check. And so that's sort of point number one. And then point number two is really avoid automation bias. So again, I didn't talk about it that much in what I said, but again, a lot of the reasons why these things become problematic and why the care was getting worse is because it encourages doctors in a very human way to stop doing all the things that they were otherwise doing. So it's like, I believe that these patients are at low risk because I've been told by the model that they're at low risk. Therefore, I'm just going to sort of switch off my spidey senses and not decide whether or not they're actually are at risk. So essentially, you should keep your spidey senses on. So that's what I say.
That's excellent. Stephen, can I ask you the same question? Is what would you recommend to people who are actually using these tools in practice right now? Given what you know, what would you say to them? And you're on mute, Stephen. So yeah.
Yeah, to start by taking on board the findings of Jess's literature review. So that's the starting point. That's the best knowledge we have about the impact of these tools as it stands. And then to think, if we still think it's worth trying something on this thing, to recognise that you're in a state of experimentation. And so build your evaluations properly, such that when you finish doing what you're doing, it might actually contribute to the next literature review that Jess or her colleagues perform in a few years' time. So yeah, go into it with a sense of humility and make sure you recognise the need for a good evaluation if you're experimenting. It's not right to experiment with NHS patients without appropriately evaluating the impacts of your efforts.
Thank you. There's a thread of questioning in the questions which I think I would characterize as sort of efforts to save the tools, as it were. I mean, and there are different strands to this. Part of it is, if only we could get better data, if only we could get richer data. I mean, Jess, you said loneliness is not currently recorded in data sets. No one says this, but there's the impulse in the chat, which is, well, what if we just got more and better data? Couldn't we just? So maybe you could reflect on that. And another strand, which is definitely in the questions, is, well, okay, we can't do it for the top 2%, but what if we did it for the top 10%? Or what if we applied this to population groups much more broadly? Or what if we went for really primary prevention using these tools? Jess, maybe you could take that set of questions on first.
Yeah, so to the better data question, yes, always better data is going to lead to better things, but what better data means is a sort of never-ending spectrum, right? So we want better data in the sense that we have a lot of the problem with these data sets is, especially in England, our data is very wide, but it's quite shallow. So we have a large population coverage of fairly basic things, but what we do not have is like deep coverage of individual types of people. And that causes a problem because often the times of what is going to improve the prediction is going to be depth rather than breadth. So you sort of have that one push, and that's where I mean in terms of having other factors like whether or not somebody is lonely, do they live alone, do they do like all of these types of things. There are trade-offs to that because there is also questions with regards to how much surveillance do we want to subject people to, because that can become, sort of an oversight all of the time, which is probably not something that we want to encourage. So there are flip sides to that. But the big thing with regards to better data in this case is much more about just validate it and then check it on the actual population that's going to be deployed. So I know of tools, for example, where it's as basic as this. The model has got, say, let's just pick an arbitrary number, 15 variables in it, right? And then they deploy it in a hospital that doesn't record 5 of those variables. That performance of that model is immediately going to drop off. Or maybe it records those 15 variables for people like me, but it doesn't record them for other people. So we know, for example, that there's around about a fifth of electronic health records in England that do not have ethnicity recorded. And if ethnicity is in a risk stratification model that we don't necessarily know it's there, but it probably is, that's immediately going to drop the performance off of that. So there are these things there, and that's what I was saying about questioning. So ask things more about this. In terms of the other question, with should we do this at a higher level of abstraction? Should we basically move towards primary prevention rather than secondary prevention and do this at a population level? So that's my instinct is yes, but that becomes much more about using it as a policy tool as opposed to an interventional tool in a sort of clinical sense. So I do quite firmly believe that if we were to use these things as more understanding modeling and like, okay, what's driving things at an incidence level and where do we intervene and what levers do we pull, we'd probably get better insight. But the argument becomes slightly circular in the sense that that then raises the question of data, because there are a lot of things that we don't necessarily record. And I'll just say one other thing, just so people have an understanding of what I mean. There's a load of really cool stuff you can do, for example, with satellite data that helps you do primary prevention at a system level. But that's not consistently available for everyone and in all locations. So basically the answer is to both questions is yes. Yes, we should do it for population level, but we therefore also need better data to enable us to do that.
That's excellent. Steven, if you could have a go at the same question, and then I'll bring us to a close.
Yeah, like Jess said, the better data likely to get better performance on the models. I remember when they built the combined predictive model, I think it was that one, they compared the effectiveness or the model accuracy with just using secondary care data than if you incorporated primary care data. And of course, the model predictions went up, but they didn't go up radically. It's not like he went from a PPV of 0.3 to PPV of 0.7. They went up, but not hugely. And I think if they're going to get really much better data, you need different types of data, as Jess was suggesting. Maybe data on routine biomedical measurements, for example, might give you better predictions. Something that's fundamentally different than what you get currently in primary and secondary care systems. But I would rather we spent time on thinking about the methods rather than the data. I think we'll get more improvement by moving from these predictive models towards causal models in the future than we would by spending more time thinking about what extra data these existing models can ingest. In terms of risk strata, so the question is, is it better, can we get these equations to stack up if we look at, say, the top 1% of patients rather than the top 2% of patients, or the top 10% of patients? Do we get better returns if we do that? The problem really is that there's a trade-off between the PPV value in the model, how good it is at predicting, and the likelihood of getting an effective intervention for those patients. So if you go for a higher risk strata per patients, your predictive power will tend to go up, but your effectiveness of the intervention will go down because it's just harder to influence the risk, the likelihood you'll get a better outcome for those patients. So moving up and down the strata doesn't automatically solve this problem for you. You just end up trading off one problem with another problem elsewhere in the equation.
That's excellent. Listen, thank you so much both. Thank you, Steven. Thank you, Jess. Thank you, Thea, and wherever you may be, I hope you've had success finding a train taking you to the place where you'd want to be. A particular thanks to Jess. I forgot to say, you dialed into this session from the States, and that you're doing this first thing in the morning as well. So very particular thanks to you, Jess, for doing that. I just want to close the session out. If we could put the slide up showing the session that we've got coming next. Just by saying this is, as I said at the outset, this is one session in a program of sessions. So we're doing many different sessions on the Neighbourhood Insights program. And the next one that we've got coming up, I'm equally excited about. I was really excited about the one today. I'm very excited about the one we've got coming up on the 29th of April at lunchtime between 12 and 1. Where we'll be hearing from Adam Lent from the King's Fund and Conor Young-Sminton from Imperial. And we'll be looking here at in a sense, some of the philosophy of neighbourhood working. And we'll be asking the question, is doing with the essence of community, of neighbourhood health? So is doing with the communities that we serve actually philosophically the essence of neighbourhood health? And if it is, how would we promote it? So I just want to recommend that to you. And then finally to say that the recording from today's session will be available, and that we'll share, as ever, we'll be sharing it across all the different StrasUnit platforms. So listen, thank you very much. That brings us to the end of the session. Thank you, Jess. Thank you, Steven. Thank you, Thea. And thank you, everyone, for your participation and questions. And we hope to see you again soon. Thank you.